Indianapolis is the place. It is the third Cardiology Sports Summit from the ACC, and I am with Professor Sanjay Sharma, who is Professor of Inherited Cardiac Diseases and Sports Cardiology at St. George's University of London in the UK. And the meeting is over, so let's take a look at what you think are really some of the big highlights from this summit meeting.
There was a lot of discussion around what we should be using as criteria for the ECG, and I think the refined criteria published in Circulation early on this year seem to feature quite a lot, and they will be incorporated in the revised guidelines, the ESC 2015 guidelines, and hopefully in the Seattle recommendations next year. There was a lot of conversation, of course, in how to differentiate between physiological adaptation and a cardiomyopathic process, because an erroneous diagnosis could have very sinister consequences. So we had wonderful talks of how thick is too thick in relation to hypertrophic cardiomyopathy, how big can you go in relation to a dilated right ventricle, and what about the other ventricle, the right ventricle. So we had some fabulous talks, and I think that particular session was my highlight. And we finished beautifully by talking about exercise recommendations in a variety of conditions, ranging from congenital heart disease to coronary artery disease to the cardiomyopathies to ion channelopathies. So a really great conference.
It seems more and more that they're backing off on some of the restrictions in terms of just don't do it. Ping pong is really all you get in terms of sports. Is that an accurate depiction?
Well, I think you're not far off in that when it comes to an athlete diagnosed with a cardiac condition that could potentially cause a sudden cardiac death, eligibility for competitive sport is really confined to low dynamic, low static sports such as billiards and bowling and table tennis. I'm not even table. I think table tennis is just too dynamic. But billiards and bowling, they say cricket, but I don't think cricket is as low static as they claim it is. But you really can't do very much competitively.
Right.
The big question really is, what can you do recreationally? We know that if you walk briskly at a 15-minute mile pace for 30 minutes, 5 times a week, you reduce your risk of a heart attack by about 50% when you hit your 50s and 60s, and you may live between 3 to 6 years longer than the individual that doesn't exercise at all. But really, the definition of recreational exercise varies from one individual to another. Many people that exercise recreationally do far, far more than that. And I think we need to be a little bit more precise on what we mean by recreational or leisure sport. I also think that these guidelines, which you are probably aware are all consensus-based, there is no evidence behind these guidelines. We need to tailor these, and there should be an excellent rapport between the cardiologist and the patient to come up with a plan which should make reference to the Bethesda guidelines and recommendations, but also should be tailored around the athlete's needs, their perceived risk as well.
There does seem to be growing interest in the whole concept of high-end athletes who do a lot of work and atrial fibrillation, and that perhaps that this kind of activity will increase. If you run even a marathon or more a year, you may have a higher risk of AF. Does that bother you? Do you tell your patients? Do you bring that up in conversation? Where are you along this particular debate?
Well, I think we're going to have to start bringing it up. There is no doubt now that there is a definite association between long-term chronic endurance exercise and atrial fibrillation, and people who have been participating in endurance sport for 20 years plus increase their risk of atrial fibrillation by 5-fold compared to an age-matched population that doesn't practice such level of sport. So I think from the data that we have at the moment, you have to have exercised for over 2,000 hours intensively. You should have been exercising for around 21 years. You're normally male and you're normally tall and in endurance sport. These are the risk factors for atrial fibrillation. Clearly, with the number of people now engaging in marathons and triathlons and Ironman, which are going up by about 5% per annum, there is a possibility that atrial fibrillation in the 60-year-old athlete could become an epidemic, and it's something that we need to start talking about, particularly whether it can be prevented, because there may be, in some individuals, that too much of this activity will predispose. So we need to find out what the predictors are in terms of, can we detect them early? and what to do when someone develops their first episode of atrial fibrillation. Do we ask them to step back, which would be my practice, or do we just suck it and see, let them carry on and see what happens?
The one thing I took away from this is there is a great deal of need for research, and that's exciting because anytime you've got a field in cardiology where you need people to get up and get research done, this is certainly one of those fields.
Well, absolutely. If you think about it, let's talk about the biggest killer in the Western world. It's coronary artery disease, and we've spent years and years researching into coronary artery disease. We research into hypertension, causes of hypercholesterolemia, and so we are all aware of how to manage AF, coronary artery disease, heart failure as cardiologists, but most cardiologists don't see athletes. And so all the data that we've got on athletes is pooled observational data, which is cross-sectional, and I think a lot of work needs to be done into the mechanisms of how these changes why these changes manifest in some athletes and not others, what's the cause behind them, what's the risk level behind some of these, and I think there is at least a decade or two of intensive research before we can get some real answers in some situations or circumstances.